In talking about the fundamental operation of the King Vision video laryngoscope, it's important to remember that because the imaging sensor is in the blade, you will not get an image on the display unless the two are connected before you power up. Now what happens is that if you power up without the blade, you're not going to get an image. If you then attach the blade after the fact, you'll get a split image. So to correct that, you just power off and back on again. Now, if you disturb this connection after it's been attached, then one of two things will happen. It will either provide a frozen image, or the screen could go blank, like that. So it's important to hold this in a way to avoid lifting on the display and disturbing this connection in use. We actually suggest that you only need to grab it with a thumb and your first two fingers. This gives you very good tactile feel as you're introducing the blade into the mouth. Also gives you very fine control if you need to manipulate it once in the mouth. In introducing the King Vision video laryngoscope blade into the mouth, there is sometimes difficulty with someone with a large chest, that the screen may contact the chest. So there's several things you can do. Obviously, if you can open the mouth a little bit wider, follow the base of the tongue, you can also rotate in from the side, or in extreme situations, you can actually introduce the blade first, then attach the display before powering up and visualizing the vocal cords. It's very important with the King Vision video laryngoscope, like other video laryngoscopes, to not attempt to get a view that's too deep. In other words, the view of the vocal cords is up close and personal. What this accomplishes is you have a great view of the vocal cords, but the imaging sensor is in the way of the advancing tube. And so it's very difficult to advance the tube, and you're typically going to run into the right border of the laryngeal inlet or the right arytenoid. If this occurs, be sure you back out, lift up a little bit before advancing the tube into position. To remove the tube from the channel, simply stabilize the tube off to the side to the right as you withdraw the blade from the mouth. And what happens is this soft, flexible overmold prevents any catching of the tube as you're separating it from the track. With the standard blade, it's important to remove the stylet entirely, make sure the tube is advanced appropriately into position, and then just simply remove the blade from the mouth. The blade curvature was designed to arrive at an appropriate compromise between being able to visualize the vocal cords by looking around the corner to allow visualization of an anterior larynx. What this means is that you will not be able to use this blade to directly view the vocal cords. But you should not have to manipulate that much to be able to visualize the cords, even in anterior larynx. Another thing to point out is that the underside of the blade is actually visible on the screen, and this is an intentional design so that there's no blind spot and that there's a landmark as to where you're placing the tip of the blade. The disposable blades with the King Vision video laryngoscope are very unique in that the imaging sensor, which is actually a CMOS camera chip, the lensing system, which is specifically designed to focus on the vocal cords, and the LED light source are all part of the disposable blade, so you get a new imaging sensor with each use. Another aspect is there is an anti-fog coating on the distal lens which prevents fogging during use and the accumulation of secretions, and there is no warm-up time associated with this coating as opposed to other systems that use a heater. There are two blades that are available with a guiding channel and without a guiding channel. This will not require the use of a stylet. The standard blade will require the use of a stylet. Currently, the disposable blades are available in a size 3, which is appropriate for most adult patients. It would be analogous to a size 3 Macintosh standard blade. The channeled version accommodates standard tracheal tubes 6 through 8. The display has a 2.4-inch diagonal OLED organic LED screen, and has a single power button that turns on and off, and is also visible at a wide variety of angles, up to 160 degrees, so you don't have to be looking straight on. It has it operates on 3 AAA batteries and roughly lasts at least 90 minutes of operation. There is a battery indicator light that begins to flash red when it's time to change batteries. You should have between 10 and 15 minutes at that point to change out the batteries. There is an automatic shut-off feature that if you forget to turn the unit off and it sits there for a minute without any motion, it will shut itself off to conserve battery life. It's also such that once you disconnect the blade from the display, it also automatically shuts off. The other nice thing about this is there is no focusing, no exposure control. There's automatic white balance, automatic focusing, and so you get a good image every time without having to futz with it. There is also a video out port that requires a specialized cable to connect. It's a mini USB, although non-standard. At the other end, it's a standard RCA plug to input into any video capture or external display. A common question we get is, when do I use a channel blade versus a standard blade? And clearly there's advantages to both styles, and that's why we've decided to offer both. The channel blade is probably the simplest to use because it doesn't require the use of a stylet. And the use of the stylet is associated with a higher incidence of trauma due to that stiffened tube passing through the oral pharynx. On the other hand, this has a larger mouth opening requirement, and so for patients with a smaller mouth opening, it's probably less appealing. With a standard blade, obviously it does require the use of a stylet, and this requires a little more preparation ahead of time to lubricate the stylet and form it and all that. But you do have the versatility of the smaller mouth opening requirement. What we've found, though, is that the indirect tube delivery method associated with the non-channeled version is technically a little bit more challenging. But if you've already mastered this technique, and all of your colleagues that might be using this device have also mastered this technique, this is probably the slightly more versatile blade to be used. In either case, because you're able to look around the corner and visualize the chords much better than direct laryngoscopy, either version should represent a decided advantage over what you're probably doing now. One suggestion would be to use the channel blade for most of your cases, but keep a few of the standard blades on hand for those technically challenging cases as they arise. Some key aspects associated with the channel blade for the King Vision video laryngoscope. This has an 18mm mouth opening requirement, and because of the channel, no stylet is required. The channel does allow standard tracheal tubes from 6 to 8mm, and it's important to note that you are manipulating where the tube goes with the blade itself, as opposed to freehand with your right hand. Now, some folks prefer to preload the tube into the channel with the tip right at the end here, as opposed to the end of the blade, before introducing it. Others, to avoid this getting into the field, prefer to advance the tube separately, or the channel separately, and then advance the tube into the channel and into position. Either way is acceptable. It's also important to note that within the channel, you can twist the tube to gain a little bit of lateral control, and obviously, to get additional anterior, you can actually lift with the blade itself. In introducing the channel blade into the mouth, as we've talked about previously, it's good to follow the base of the tongue and visualize the epiglottis, and even put the tip in the vallecula, much like a Macintosh blade. As you advance the tube, you can see you can get a little fine control to advance the tube, center it so that it goes towards the vocal cords. And if you want to capture a long floppy epiglottis. Again, you can get a little fine control with manipulating the tube to center it going through the vocal cords. And actually, the closer you get to the vocal cords, the more likely you are to run into the right border or the right arytenoid. And if that's the case, then what you're going to have to do is retract the tube, and you'll have to twist it even further to the left to advance it into the laryngeal vestibule, and then rotate it back to the normal position to advance it into the trachea. For an extremely anterior larynx, we've actually seen another technique that can be used, that if you can't, for whatever reason, lifting, manipulating with the tube, you just can't get the tube to enter the laryngeal inlet. You just need a little bit more anterior deflection. You can actually use a bougie with the coude tip angled anteriorly within the tube, positioning the tube right under the opening to the larynx, using that angulated tip to advance the bougie through the vocal cords into the trachea, then advancing the tube, again watching it to make sure it goes in the trachea, withdrawing the bougie and removing the blade in the normal manner. In terms of the use of the standard blade with the King Vision video laryngoscope, it's important to note that the mouth opening requirement here is only 13 millimeters. So it does give a little bit of versatility in accommodating smaller mouth openings. The lack of a channel means that you are going to need to use a stylet to indirectly manipulate the tube into position. Now, three things to remember in operating the stylet. First of all, when it's installed, you want to make sure that the tip doesn't stick out the end of the tracheal tube, because that's more likely to be traumatic. It's also very important to make sure that the stylet is lubricated ahead of time to make it slide in and out very easily. Also, you don't want to form the stylet to give you the curvature. You want to do the stylet inside the tube, because it may give you a little bit different curvature because of the sloppy fit. Typically a 60 to 70 degree angulation of the stylet, maybe 2 to 3 inches from the end of the tube. So fundamentally, following the base of the tongue, as we've talked about before, putting the tip of the blade into the vallecula above the epiglottis, or underneath the epiglottis like a Miller style. Now you'll notice that I'm going to be actually looking in the mouth and following with the tip of the blade, or the tip of the tracheal tube, follow the curvature of the blade until I reach the posterior wall of the pharynx. Then I'm going to look up at the screen and watch as the tip approaches the vocal cords. Put it right at the entrance, then advance the tube off the stylet into the trachea, remove the stylet, and then remove the blade. An alternate insertion method would be to use a more of a retromolar approach, which doesn't require as much curvature, because you're cutting the corner, so to speak, rather than following the blade curvature. So again, placing the tip, visualizing the vocal cords, but now you're kind of coming in from the corner of the mouth, outside the molars, and if there is sufficient room in this patient, you can actually get a more of a straight shot, which makes it a little bit easier to deliver the tube in some cases. Both of these techniques, following the curvature of the blade, shaping the stylet accordingly, or using the retromolar approach, both have been used very successfully. This is a common question that we get: when are we going to have pediatric sizes, or what size patients can the existing size 3 blades be used on? Clearly we're working on the pediatric sizes. The dimensions are clearly different. It's not just a downsizing. The anatomy does change with the development of patients from infants to adults. Again, the analogy is whoever you would be comfortable using a Macintosh 3 blade, and this would obviously include some adolescents and larger kids, but it's clearly up to the clinician and looking at the size of the patient as to when they would be comfortable using either blade. And obviously the mouth opening requirement would be a factor as well. We often get the question of how durable the King Vision display is because of the environment in which it is used. And clearly that we recognize there's going to be times that it's inadvertently dropped. With this in mind, we did submit this to standardized safety testing, which included a drop from a 4-foot height onto a tile floor in 3 different orientations to make sure that it survived the safety requirements. Clearly, we've built in inherent features with the adhesive and the construction to make it as durable as possible. However, nothing is totally shatterproof or break-proof, and certainly, one can be reminded that your iPhone, if you drop it and the screen cracks, it's not covered by a warranty. So while this will likely survive most drops unintended, this isn't something we would advocate doing it as part of a demo. It depends on which version you're using. If you're using the standard blade, clearly lubricating the stylet is important, and depending on the level of secretions in the patient, you might want to lubricate the tip of the blade a little bit. You certainly want to avoid getting any lubrication that might cover up the lens. And you might lubricate the tip of the tube a little bit so that it slides through the vocal cords very easily. With the channeled blade, a little bit different. You don't have the stylet. You'll probably want to lubricate the outside of the tracheal tube a little bit to make sure that it glides through the channel relatively easily. Again, a little bit of lubrication on the tip, and maybe even on the bottom side if it's a tight airway. We've actually heard this question on a number of occasions, and in designing the product, we realize from an optical standpoint that you have to have anti-glare coatings on every surface built into this, and so we've actually integrated that into the design. Now, in absolute bright sunlight, there will be some washout, but we've actually had some very favorable reviews that you can actually still see the vocal cords and accomplish the intubation even in bright sunlight. This is a very common question we get, particularly with winter approaching, and certainly we've validated that the King Vision can be used from 10 degrees C to 40 degrees C. The important thing to note, though, is that this is the temperature at which the device equilibrates at that it will operate. So if the anticipation is that this will be used in colder temperatures, obviously you're going to want to keep this warm. It doesn't mean that immediately, once you take it out into these sub-zero temperatures, that it will not work. And primarily it's the batteries getting cold that will allow the operation to stop. So keeping it at room temperature, which is typically what happens in trucks or whatever, particularly in emergency use, would be recommended. And it will certainly work outside of that for a period of time until the device becomes equilibrated. It's also important to point out that this is not unique to the King Vision video laryngoscope. Any plasticized PVC devices like tracheal tubes, which are used in conjunction with this, they become very rigid at cold temperatures and would act like a spear that you're trying to put in the airway. So you need to keep all these devices warm until you're ready to use them. In discussing the cleaning and disinfecting of the King Vision, it's obviously important to note that the disposable blade is what is typically contacting the patient, and it's typically what you're holding on to as you're using the device. And as the tracheal tube is positioned, you back it out of the patient. The patient's intubated. You separate the blade from the display. The disposable blade is then actually discarded, and this is the only thing that's reused. It's important to note that because of the electrical connection on the bottom of the display, it is not fully submersible. So in cleaning and disinfecting, make sure that you don't get any liquid into that electrical connection. And in fact, it's best to hold it upright so that as you're applying any solutions, it really has no way of getting in there. We would suggest you use a 4x4 or some sort of wipe that's moistened with either the cleaning or disinfecting solution that we would recommend to just wipe down the device so that you can avoid submersion. Now typically, because you're handling the blade and you don't have much patient contact, it's just wiped down with an isopropyl alcohol wipe between uses. And clearly this would just be a matter of wiping down, and you make sure that particularly on the power button, the crevices there, any places where it might have been handled, that you wipe that down. And typically this would be a totally acceptable way to disinfect this between uses. If the display becomes visibly soiled, which certainly can occur, especially in emergency situations, we do offer complete, validated cleaning and disinfecting instructions in our instructions for use, our IFU. Essentially this involves wetting the towels, as we talked about, or the 4x4s or the wipes, with an enzymatic cleaner for cleaning, and wetting these wipes or 4x4s with isopropyl alcohol for disinfecting for the specified time in the IFU. Now, we do also include alternate disinfecting solutions that are compatible with the King Vision display.
The iGel is a novel and innovative supraglottic airway management device made of a medical-grade thermoplastic elastomer, which is soft, gel-like and transparent. It took over 5 years of development to perfect a non-inflatable anatomical seal of the pharyngeal, laryngeal and perilaryngeal structures that would reduce compression trauma. A supraglottic airway without an inflatable cuff has several potential advantages, including easier insertion, minimal risk of tissue compression, and stability after insertion. iGel is a latex-free single patient use device that has a gastric channel to reduce the risk of aspiration. Key components and their function. The soft, non-inflatable gel-like cuff matches the shape and softness of the laryngeal and perilaryngeal framework. It helps to provide easy and rapid insertion and reduces the potential for post-operative trauma. An integral gastric channel is provided to reduce the risk of aspiration and allow for passing of a nasogastric tube. The buccal cavity stabilizer eliminates the potential for rotation and aids insertion. An epiglottic rest helps to prevent the epiglottis from downfolding or obstructing the distal opening of the airway. The 15mm connector extends inside the airway tube far enough to provide an integral bite block.
Pre-insertion preparation. iGel is supplied in a sterile pouch enclosed in either a protective cradle or a cage pack. This innovative packaging is color-coded for size and designed to ensure the device is maintained in the correct flexion prior to use. It also acts as a base for lubrication. Select the appropriate size eye gel according to patient weight.
When selecting size, it should be remembered that the eye gel cuff does look smaller than the corresponding size of many traditional supraglottic airways with an inflatable cuff.
Ensuring that you conform to local policy for hygiene, open the eye gel package and on a flat surface take out the protective cradle or cage pack containing the device. In the final minute of pre-oxygenation, remove the eye gel and place a small bolus of a water-based lubricant, such as KY jelly, onto the middle of the smooth surface of the cradle or cage pack in preparation for lubrication. Do not use silicone-based lubricants. Grasp the eye gel with the opposite free hand along the integral bite block and lubricate the back, sides and front of the cuff with a thin layer of lubricant. This process may be repeated if lubrication is not adequate. After lubrication has been completed, check that no bolus of lubricant remains in the bowl of the cuff or elsewhere on the device. Avoid touching the cuff of the device with your hands. Place the eye gel back into the protective cradle or cage pack in preparation for insertion. Do not place the device onto the pillow or chest of the patient. Always use the protective cradle or cage pack. Do not use unsterile gauze to help in lubricating the device. Do not apply lubricant too long before insertion. And always ensure dentures or plates are removed from the mouth before attempting insertion. The eye gel must always be separated from the protective cradle or cage pack prior to use. These are not introducers and must never be inserted into the patient's mouth.
Insertion technique. A proficient user can achieve insertion in less than 5 seconds.
Remove the eye gel from the protective cradle or cage pack.
Grasp the lubricated eye gel firmly along the integral bite block. Position the device so that the eye gel cuff outlet is facing towards the chin of the patient. The patient should be in the sniffing the morning air position, with head extended and neck flexed. The chin should be gently pressed down before proceeding to insert. Introduce the leading soft tip into the mouth of the patient in a direction towards the hard palate. Glide the device downwards and backwards along the hard palate with a continuous but gentle push until a definitive resistance is felt. Do not apply excessive force on the device during insertion. It is not necessary to insert fingers or thumbs into the patient's mouth during the process of insertion. If there is early resistance during insertion, a jaw thrust or insertion with deep rotation is recommended. When inserted to a definitive resistance, the tip of the eye gel should be located into the upper esophageal opening, and the cuff should be located against the laryngeal framework. The incisors should be resting on the integral bite block. The eye gel has a horizontal line on the integral bite block to indicate the optimal position of the teeth. But the teeth may rest safely anywhere on the integral bite block. The eye gel should then be taped down, maxilla to maxilla. When inserting the eye gel, it should be remembered that partial resistance and then a feeling of give way may sometimes be felt before the endpoint resistance is met. This is due to the passage of the bowl of the eye gel through the facial pillars. This is quite normal and consistent with correct insertion, but in such cases, insertion needs to continue until definitive resistance is felt. Let's look at some eye gel insertions in real patients. Note the sniffing the morning air position and the gentle press down on the chin. See how there is no need for fingers to be inserted in the mouth. There is never a need to apply excessive force or to repeatedly push down on the device once definitive resistance has been felt. how to use the gastric channel. If required, a nasogastric tube can be inserted down the gastric channel of the eye gel. For a quick and efficient insertion, it is important that the nasogastric tube and the gastric channel of the eye gel have been adequately lubricated before insertion is attempted. The ideal way to achieve this is to place a small bolus of lubricant over the proximal end of the gastric channel. The nasogastric tube should then be inserted a short way down the channel and moved in and out to prime it before completing insertion.
The maximum size of nasogastric tube that can be inserted down the eye gel is size 10 French gauge for a size 1.5, 12 French gauge for a size 2, 2.5, 3 and 4, and a size 14 French gauge for a size 5 eye gel.
In summary, eye gel is a simple and effective alternative to traditional supraglottic airway devices. Eye gel has been designed to eliminate the need for an inflatable cuff and create a superior anatomical seal mirrored to the pharyngolaryngeal structures. It includes a gastric channel to reduce the risk of aspiration and is very easy and rapid to insert.
Video recording.
Look at that. Mouth மட்டும் open பண்ணுமா லேசா இப்படி லேசா அமுக்காத லேசா open பண்ணு. Can you see that?
Yes, sir.
That's all.
Photo test, chest expansion.
No. Show the EDC.
with it.